Well done. Thank you very much. Claire, I must talk to you. First of all, congratulations on your promotion, Deputy Head of Therapy. That really sounds good. Would you like to expand, please, on your job?
Absolutely, I'd love to. Speech and language therapists are allied health professionals. And you may be more familiar with some AHPs than others. You probably have heard of physiotherapists and occupational therapists, but there's quite a lot of us, and it includes people like dietitians or even radiographers. The speech and language therapists specialise in dealing with communication difficulties and with swallowing difficulties. And it's the swallowing difficulties that we really wanted to talk to you about today. So if you know someone who comes into hospital, maybe they've had a stroke, or they've fallen, perhaps they've had a head injury, or they've got Parkinson's disease or MS, or even dementia, there's a really good chance that they may have swallowing difficulties and will need to see a speech and language therapist. So lots of different conditions can cause dysphagia or swallowing difficulties. And essentially I'm talking about food and drink that's going the wrong way. So sometimes there's some really obvious signs of that. People can cough and choke and splutter, but also they may get dehydrated or may lose weight. But one of our biggest concerns is that sometimes you don't show the outward signs, but food and drink is heading into the lungs. And if that happens, that essentially means that person will get a chest infection. That's foreign material that's in their lungs, and that will cause them to have what we call an aspiration pneumonia. Now, a lot of these people are frail and elderly, but also if you can't move around for yourself and you're in bed, that aspiration pneumonia can be really, really dangerous and actually can be fatal for some people. So the speech and language therapist's job is to assess that swallow, to assess the dysphagia, to try and find something that's safe for that person to eat and drink. But if we can't do that, we sometimes end up recommending that people stay nil by mouth, which means they can't eat or drink anything. In which case they might need a feeding tube in order for them to get the nutrition and hydration that they need. So it's the speech therapist's job to assess that and try and advise the doctors and the MDT on the best way of moving forward to help people eat and drink.
Got you. Well, I must admit, before this webinar, I always thought that speech therapy units were mainly for children. But I realise now, Catherine, that actually you're looking at people who are actually very, very ill to start off with. Yeah. What tools do you have at the moment to assess that sort of thing?
So at the moment, as Claire said, it is very complex. Dysphagia is very complex. And at the moment we have an X-ray that for those patients that are very complex and they've just got a chest infection, we're not sure what's going on with their swallow, that we're able to take them to the X-ray. But the wait for that is 5 days. So the reason we're fundraising for this equipment is that, well, one of the reasons is to cut down that wait time. So this equipment is a camera. It's called a FEES, Vibroendoscopic Evaluation of Swallow, quite a mouthful. And so we put the camera up the patient's nose, we give them something to eat and drink, we make sure it's going the right way into their stomach and not the wrong way into their lungs. Now, this assessment, we can be very responsive with. We can take it to the bedside and we can do it within a day. So I'm fully trained to use this equipment. I've been using it for 5 years and I've trained clinicians in London and in Bristol, and it would totally transform the way we manage our patients. Like a lot of trusts haven't been able to implement this because of the training costs involved, but we don't have that as a problem. Another reason that we want this kit is one of our problems is when we see patients on the intensive care unit, they're our most complex and most vulnerable, but we can't get them to the X-ray. They have to stay in that supportive environment and they're our most unwell. So with these patients, we have to either be very, very cautious and keep them nil by mouth for longer, or it might be that there's some unnecessary risks taken and they might become unwell. So with this kit, we can take it to the bedside and we can assess them and keep them safe. And so safety is a big factor with this, and it's a safe procedure. We don't have to expose people to X-rays when we do it, and also there's less staff involved, and for costs as well, it reduces the amount of cost, because an X-ray would be, according to data within Bristol was £450 versus £60 to do this procedure, so it's a lot cheaper. And finally, in weaning patients off tracheostomies, research shows us that this would help get the tracheostomy out faster. For patients, obviously, that would be much better for the patient, and also we can ideally get them off the intensive care unit, thereby reducing costs as well. So it's quite a big change.